a quick guide to systemic migration of boundaries. In obstetrics, imagine you are driving to work on a motorway. The legal speed limit is 70 miles per hour. But what speed do you drive, and how do you make that decision? The Highway Code is a document we have all read as drivers. We have all passed our driving test. The Highway Code states it is illegal to drive above 70 miles per hour on the motorway. The reality is that life pressures, our perceived vulnerability, and our belief systems mean that we are continually driven to break the rules. Many of us will happily drive 75 miles per hour on the motorway. This is known as the illegal normal space, and if we don't have an accident or get caught speeding, driving at 75 miles per hour becomes normal practice to us. So the next time we get into our car, we may drive 80 or even 85 miles an hour. We know that this is illegal, and we know the chance of getting caught or having an accident are higher, but because this hasn't happened, we are not driven back to driving at the legal speed limit. What I've just demonstrated is systemic migration of boundaries. So, let's use this example within obstetrics. Imagine you are the midwife looking after a low-risk primogravida in spontaneous active labour. After 2 hours of active pushing, you diagnose delay in the second stage, and birth is not imminent. You know that the NICE guidelines state you should refer to a healthcare professional trained in undertaking operative vaginal delivery. However, there are no fetal concerns, and although delivery is not imminent, you encourage the woman to continue to push. After 3 hours, the baby is not born, and you contact the registrar for assessment. The result is that the patient's care has entered the illegal normal space. Often, as any healthcare professional working under pressure, we regularly work within an area called the borderline tolerated conditions of use, within the illegal normal space. This is often referred to as the real world of work. We feel safe here, as adverse outcomes in this area are rare. This area becomes our usual level of performance, even though it lies outside the safe field of practice defined by our protocols. We often work here because it may increase our productivity and save us time. Over time, the results of frequent migration into the illegal normal space become normal practice, and so the culture as a whole migrates. No one incident reports these migrations, as these violations outside of safe practice have become routine and tolerated. However, this migration of boundaries creates anxiety and tension between following protocols against our productivity, and that anxiety drives human error. So, if most people are working within borderline tolerated conditions of use and this impacts patient safety, how can we manage these migrations? We need to acknowledge that these migrations occur in order to create a just culture so that people can openly report their errors. Opening discussions between staff and managers helps to establish a shared safety culture. We may need to adjust our protocols to reflect the real working world, whilst also agreeing what should be the forbidden space for all staff. The overall aim is to establish a shared, common goal of patient safety.